Here we want to demonstrate the atraumatic extraction of a non-restorable maxillary lateral incisor tooth. This tooth was deemed non-restorable with a fracture in it. To numb the area, what we're going to do is we're going to use a attachment to our standard syringe. It's called a Vibrajack through Golden Dental Solutions. And it vibrates the needle such that the motor effect of the vibration blocks the pain receptors. And I would say about 80% of my patients notice a dramatic improvement in the discomfort with that initial penetration of the needle. And that same holds true with the palatal injection. The physics forceps is a unique tool. It has two components, a beak and a bumper. The beak is engaged onto the palatal surface of the root, 1 to 3 millimeters. The bumper is placed as high up the vestibule as possible, and with simple rotation of the wrist towards the left nostril, and you can see I'm not squeezing the instrument at all. There's no forearm bicep or shoulder pressure. I'm simply rotating my wrist, and in a matter of seconds, the tooth will dislodge up and out of the socket following the arc of rotation of the instrument itself. Physiologic reaction is an enzymatic release which breaks down the periodontal ligament, and again in a minute or so the tooth will literally pop out of the socket. The instrument is not intended to remove the tooth in total. Here you see that the tooth is coming up and out and has been luxated. Tooth delivery instrument is simply an instrument to grab onto the root structure facially and palatally, and with a simple rotation I'm able to remove the tooth root in one piece, maintaining the facial plate of bone, maintaining the interseptal bone and the interdental papilla. This is very important in the aesthetic zone. A difficult extraction becomes very routine using the golden physics forceps. We want to, here we can see the curvature of the root. We will take a sharp curette and simply curette any granulation that may be present. We're also evaluating the facial wall, which is certainly intact in this situation. And we are now prepared to place our implant. We're going to do some measuring using the Hahn 2.4 diameter pilot burr. And you can see here that we're actually going to position the burr not into the socket itself, but rather on the palatal aspect of the socket wall. About 3 millimeters palatal to the facial aspect of the adjacent teeth. The rotation is about 1,000 RPMs, and again we're going to use the 2.4 pilot drill to make our initial osteotomy preparation. At this juncture you can take a radiograph to make sure your measurement is correct. We decided on a 16 millimeter by 3.5 millimeter diameter Hahn implant. This is the 3.5 diameter Hahn osteotomy burr to depth at 1,000 RPMs. Now we do have a defect in that the socket is shaped more like an egg, and we are going to fill that defect with our synthetic bone material. This happens to be an osteogen plug, which is made up of calcium and phosphorus particles in a non-sintered matrix. And as we know, osteoclasts will invade the site and osteoblasts will lay down new bone. It's a very, very predictable way of allowing bone formation. So I'm taking this plug and I'm simply very gently placing it into the socket site, which is filling the gap, and then I'm going to simply thread my implant into the grafted material. The Hahn implant is very, very innovative. The design, it has aggressive threads and a bevel taper. We will place it with our handpiece at about 25 Newton centimeters of torque at about 25 RPMs, and you can see how slow we're engaging the osteotomy site. And at 25 Newton centimeters, the handpiece will actually stop. At this point, you can take a radiograph. We want to eventually place our implant about 1 millimeter subcrestal. Here's our hex tool. We're setting it at 30 Newton centimeters because the implant's already engaged at 25 Newton centimeters. And I'm going to place the implant into proper position using the torque wrench. And it will actually click, you'll hear it click at 30 Newton centimeters, and we know that we have 30 Newton centimeters of torque, which is great initial stability. I decided, because the patient's going to wear a transitional appliance, just to put a cover screw into the implant and allow the area to heal uninhibited by any type of pressures created by chewing or food or any kind of design. Here you can see the graft and the implant in ideal position. Final radiograph illustrates the implant and the grafted site. We will allow this site to heal for about 4 months prior to continuing our final impression and implant retained crown formation.